Good evening, everyone, and thank you so much for coming and joining us tonight. Esther and I are part of your supportive care department here at Stanford, and we are really excited to have a wonderful panel of speakers. This is our first lecture of the year. It's on fiscal therapy, navigating the narrows of financial responsibilities and resources for chronic illness. And so we have quite a lovely panel. We have Libby Boatwright. I don't know what all your initials mean, but I know her because she's a palliative care counselor and advisor, certified, financial planner. We have Gary Bertuccelli. He's one of our social workers. We have Kelly Bugos from the survivorship program. She's an RN, NP. Connie Holt, who's an independent insurance broker, and Phyllis, Garza, and Anna Brown from our financial department. They're our financial counselors. And so without further ado, we are going to get started. All right, thank you so much. Before we get started, I would like to ask you to silence your phones. We are videotaping this. You won't be videotaped, but we are videotaping the lecture. So if you don't mind putting your phones on silence, we'd appreciate that. All right, thanks so much.
Thank you so much, Darla. Again, we welcome you to this seminar on fiscal therapy. We're also thankful to the Cancer Supportive Care Programs and especially to Esther and Darla for allowing us to come tonight. This is part of the Ernest Rosenbaum Survivor Lecture Series. It's truly an honor to be here. Our evening tonight really has three objectives. It is to introduce the choices involved in comprehensive medical care and the financial responsibilities that come with those choices, and to introduce the resources available here at Stanford and in the community, and finally to connect people to the kind of resource people available and encourage dialogue and communication regarding this very important topic. And to handle these objectives, we've assembled a panel of professional resource people. I'm going to introduce them as they come up tonight. And the first is Connie Holt. Connie began working as an insurance professional in 2004. She began by marketing health plans to individuals and families, provided life insurance and annuities to the federal employees of the city of San Francisco, and in 2008 founded her own agency and began working as an independent broker. Today, her agency, Goldsum Insurance Solutions, focuses on Medicare, health plans, and life insurance in California, Washington, Nevada. There's a long list. Arkansas, Arizona, and Oregon. She has hundreds of clients who look upon her as their trusted advisor. Welcome, Connie Holt.
Thank you, Libby. I, too, am very honored to be here. And we're just going to go right into it. As you can see, our first topic is the Affordable Care Act. You may have heard of that. Obamacare, it's the same thing. This is insurance for people under 64. And under 65. The plans are labeled as metal tiers. They're bronze, they're silver, they're gold, and they're platinum. The richer metal, platinum, is the richest health plan. If you look at the next one, Covered California, that's called an exchange or a marketplace. This is where Californians who are under 64 can purchase health insurance. Now, you wouldn't want to purchase here unless you qualify for a tax credit. And you qualify for a tax credit by your income. So if you don't purchase it through Covered California, you're going to get it directly from a carrier like Blue Shield, United Healthcare, any of the number. And they all vary by county. So we have to look to see who's available in your county, who's offering coverage. And open enrollment for this is November 1st to January 31st. And I would contact a local agent. Have them guide you. It makes it so easy. Here are the standard benefits for each plan. You can see that there's bronze, silver, gold, platinum. Platinum covers 90%, so it is the richest in benefits. That means you owe 10% of the bills. Bronze, if you look at that, it's 60% coverage, meaning you owe 40. And accordingly, if you get a platinum plan, your premium is going to be much higher than a bronze. So let's look now at insurance for people that are over 65, and that is a program called Medicare. This is the largest health care program in the United States, and millions of people are going to be on it more and more as we grow older. And this is for people typically who are over 65, or 65 or older, but some younger people can participate depending on the kind of health condition they have, or if they've been on disability for 2 years. You can also qualify early for Medicare. You have to qualify, and to do so, you've worked in the U.S. for 40 quarters at least, and you've also paid in through your payroll taxes, and that helped pay for Medicare. You must be a citizen or a lawfully present here, and you must have resided here for 5 years consecutively in order to qualify. You can buy into it, and many people come here from foreign countries, and they do purchase it just like any other health insurance plan. There's 4 parts to Medicare. Part A and B, that's considered your original Medicare. And Part C is the Medicare Advantage plans, and these are HMO plans. Okay, these provide coverage in with a certain network in the HMO. Part D is your prescription drug coverage. Both C and D are provided by private insurance carriers. A and B comes from your government. So we'll look a little closer here at A. You're automatically enrolled at age 65 typically. And that's because, like I mentioned, you've worked long enough, paid in enough to qualify for it. So that means your premium would be 0. And what's covered under Part A is anytime we're in a hospital bed, whether it's the hospital, the skilled nursing, the rehab center, hospice, Part A is working for you. But it doesn't cover everything. And a lot of people think Medicare covers everything, but it doesn't. As you can see here, if you went into a hospital and you had Part A for your medical coverage, you would owe a $1,340 deductible. And that will cover you for 60 days in the hospital. After 60 days, though, they're going to start charging you a daily fee. After 90 days, they're going to charge you a higher daily fee. And so this is why health plans are very important, as you'll see later. So Part B is the second part of original Medicare. Now, you must elect to enroll here. We have not prepaid for this, so you'll have to choose it. When you turn 65, if you're collecting Social Security, they're going to send you a card automatically. It's going to show you're enrolling in A and B. But at that point, some people are still working. They don't need to enroll in B, and you don't have to. As long as you have creditable coverage, maybe from your employer, you can delay enrolling. If you do delay and you come back later to enroll in B and to activate it, you'll go to your Social Security office and apply. Now, B covers all the outpatient services, our MRIs, our doctor visits, our labs, but it's also working when we're in a hospital. So when the doctor walks into your room, or they provide medications, or do any testing, Part B is working there. And the standard premium for Part B is $134 based on income, though. And I'll show you a chart that shows you if you're a higher income earner, you'll pay more. Part B has a deductible. It's $183 a year. And after you've met that deductible, you'll pay 20% of all the bills. And there is no cap. So that 20% that you owe goes on and on. So this is what I was talking about for higher income earners. If we make $85,000 a year or lower, our standard premium for B is $134. If you're married, $170,000 a year allows you to pay the $134. If your income goes up from there, you'll see you'll pay accordingly. And that would be just for Part B. So you've seen what Medicare is not paying and all the expense that comes out of your pocket. So we have to ask, how do we cover what Medicare doesn't? And that's where the Medicare health plans come in. So here's 3 options that people choose. The first one you'll see is Medicare A and B, and you just add a drug plan to it. Now, some people, that's what they go with, and they would owe 20% of all the bills, plus the deductibles, okay? So option 2 might be better, and that gives you a Medicare supplement, which is the medical coverage that's going to pick up what Medicare doesn't pay, and a drug plan. So you've got 2 separate plans there. Option 3 is that Part C that I mentioned, a Medicare Advantage plan. These are all HMOs in Northern California. That's all you can choose from. And but Either way you go, they're very good plans. Here, let's break it down a little bit more. To get a health plan, though, to enroll in any health plan, you must have A and B active. So you must continue to pay for B. And in addition, then you pick up a health plan. And the supplements is one option. And with these, you can access every doctor who takes Medicare in the U.S. There are no referrals necessary, so there's no network restrictions. It does require that you buy a separate Part D drug coverage plan, okay? So you would have 2 premiums. They are guaranteed renewable. Nobody can take it away from you, even if they cancel the plan. And on the other side, the Medicare Advantage, these are the HMOs. These are managed care plans. You must stay in a network. If you are in Santa Clara County and you go into San Francisco, there you're covered for emergencies only, okay? So they are more restrictive with networks, but they do provide wonderful managed care. Outside your area, like I said, ER coverage only, but they do offer worldwide ER coverage. Some plans put a dollar limit on it, some don't, so you just have to check. And most of them include Part D, so you've got 1 premium, which is nice. So how do we enroll, and when can we enroll, and when can we make a change once we've enrolled? They have election periods that allow you to do that. The initial election period is what most people experience first. When you turn 65, they give you a 7-month window to enroll, and that's your birthday month that you turn 65, 3 months before and 3 months after. You've got a full 7 months to enroll in any plan on the market, guaranteed issue, which means no medical questions asked. The only one would be, do you have end-stage renal disease? That's it. And once you're enrolled, your annual election period comes around every year, October 15th to December 7th. And that's when you can make a change and or add a plan, do anything you want. This is where we analyze what you have and make sure it's still working. During the year, things happen. People make changes. They move, or they may, maybe they've lost their group coverage. There are special election periods for those situations. There again, you would be guaranteed a plan, any plan you choose on the market at that point. Now, some people do delay enrolling in B during that initial election period, and that's fine as long as you have coverage elsewhere. Okay, all right. So there are programs to aid people who need help paying for their drugs. One of those is called Extra Help, also called Low-Income Subsidy. And people can qualify for this even if you make too much money to qualify for Medi-Cal. So it's a wonderful program. It can cover your monthly premium for your drug plan. It can cover your deductible. And then it could give you 0 cost for your drugs. Or the generics could cost as little as $3.35, the brands as little as $8. Okay, so it's a great program. It is worth checking to see if you qualify, and your agent can help you do that. There are processes in place if we are not happy with the decision our healthcare provider has made, such as your doctor asking for a test for you and the insurance company refuses to pay. You can file an appeal for that and have it reconsidered. And these are all set up, they're easy to do, and you can get help doing them. Grievance or complaint would be a situation where you've gone to your doctor's office and it's dirty, or they're making you wait 6 months for a visit. Any kind of complaint like that for your services would be considered a grievance or a complaint. And there again, there's a formal process. Your broker can help you with that. And sometimes it depends on who you're complaining about, but even the health plan could help you. There are resources like your Medicare handbook. That is mailed out to you every September, the end of the month. And if you don't get one, you could call 1-800-MEDICARE. That line is open 24 hours a day. They make it very easy. You could also download one from Medicare.gov, and that's the website that's full of information about Medicare. Now, if you do it that way, it won't be unique to your area, but you will have all the general information you need there. Here are some resources. Your independent broker obviously is one of your main resources. They're the ones that can be your advocate and your trusted advisor. The State Health Insurance Assistance Program, or SHIP, That includes HICAP, and they will give you in-person counseling. They'll also do it over the phone. During the year, they'll do presentations around the different areas, such as your broker might do, and very valuable resource there. Social workers in the hospitals, you have inpatient and outpatient social workers to help you. And some health plans have a program called My Advocate. And My Advocate is a program that will help you, they'll help you to see if you're eligible for some of the community services, such as the extra help. So don't hesitate to ask your insurance carrier or your broker if they provide that kind of service, and most do. So if we look at some of the terms that you hear with health insurance, of course, the first three, if you've had a health plan, you've heard these terms. So there's the copay, so I go see my doctor and I have to pay $20. That's a fixed amount, and that's considered a copay. Coinsurance is what we talked about with Medicare and with the Affordable Care Act plans, such as Platinum covered 90%, you owed 10%. Well, that's a coinsurance. So your coinsurance would be 10%. The deductible is what we have to spend before the health plan starts covering anything. Now, I mentioned Part B has a $183 deductible. So most of us have experienced those with our group plans. The exception, let's say you've enrolled in a Part D plan. Now, remember, there's an open enrollment. So we enroll and we keep it for the year. 6 months into it, you have a new diagnosis and a new drug you need. Well, it's not on the drug list with your carrier. So your doctor can file a formal exception. That's a process to have your insurance company, or to request that your insurance company cover it. And they'll let you know if they do. Okay? And then at the end of the year, we would re-examine and research the drug plans to get a better one for you. Okay? The exchanges, there again, covered California is our exchange here in the state of California. And it's called a marketplace. This is where if you're under 64 and you earned a tax credit, you would go here to purchase your insurance. The formulary, all the insurance plans have a formulary, which is their particular list of drugs that they will cover. And it's very important that you research these based on your particular list of drugs, because it's unique, and that's how you're going to get the best coverage. So HMO and PPO, these are two types of health plans. The HMO is what I mentioned with Medicare Advantage, and that's a health maintenance organization, and these plans offer coverage as long as you use their network of providers, and they do offer managed care for you. The late enrollment, let me go back. The PPO is the Preferred Provider Organization, and that one allows you to see doctors outside the network, but they just won't cover it as much. So you've got more out of pocket if you go out of network. Now, the late enrollment penalty, this is very important. When we become eligible for Medicare, the government expects us to enroll in Part B and Part D, the drug plan, if we don't have coverage elsewhere. So if we have group coverage from our employer, no problem. But if we don't, and we don't enroll at that time, later on when we come back to enroll, they will place a penalty on us, and it will stay with us for life. So that $20 Part D premium that you're supposed to pay now may be $45 because you've incurred that late enrollment penalty. So you really want to be careful with that. And a broker should guide you into that and not let that happen for you. Okay, special needs plans in Medicare, they actually have plans that cater and are tailored to distinct conditions such as diabetes or cardiovascular disease, things like that, pulmonary disorders. You can actually pinpoint a plan on that. So the tiers, and a lot of people already know about tiers, this is how drug plans determine what your medication cost. So if your drug falls in a tier 1 or 2, then you've got a lower cost generic. Tiers 3, 4, and 5, that's your more expensive brands, some of the specialty. This is where some of the infusions, or not infusions, but maybe you're administering shots at home, drugs like that. All the new drugs that you see on TV would be in these higher, very expensive categories. Thank you very much.
feel like it's from the fire hose. You've got so much going on tonight, but it's wonderful and very important information. Our next speaker is Kelly Bugos, and she's a nurse practitioner who has had the honor of working with people touched by cancer for over 30 years. Along the way, she has met some remarkable people who have shared their experiences and questions and taught her that the gift of life comes at a price. We welcome her tonight to share some of her learnings, including the value of asking good questions. Please welcome Kelly.
Good evening. Can you hear me? Excellent. So in the next 10-ish minutes, I'm hoping to give you some information and stimulate some questions about how communication approaches and decision-making can help get the type of care that we each want. So first I want to take you down kind of a historic road, and that is that if you remember back in the day, a long time ago, certainly at the early part of our lives, medical decision-making was very paternalistic. The physician decided what the ailment was, decided what the treatment would be, and gave it. And then as time went on, there was a style called informed decision-making, which was still the physician deciding what was wrong and how to treat it, but actually informing the person ahead of time of what was going to happen. And that was called informed decision-making. And these two styles still exist in our country, but what's become much more common is shared decision-making. And this is a style where the healthcare provider is considering what could be wrong, is thinking about what possible options are for treatment, and then having a discussion with the person who has the ailment about how those treatment options may work for them. And that allows for people to state their preferences, to think about their values, and communicate it with the healthcare provider so that together they make a decision. This is a style that we as healthcare providers are striving to achieve today. And the reason is because we think it's the best option of someone who has expert knowledge, sharing it with the person who has the ailment, and then the person who has the ailment considering how this will work in their life or not. And so why is that? Well, part of it is because you know you better than anybody else, ever. And so what's really important is to be able to not only know, but then communicate in a very vulnerable place. When we're ill, we are extremely vulnerable, and we give ourselves over to a system that uses a language that many of us have not been familiar with. And so some of the ways to try to let the healthcare provider know what's important to each of us is to think about it, and then to use some tools or a tool to be able to describe that. So some is to be able to say it, but in short healthcare visits, that can be difficult. And so there are some tools. One's called the Stanford Letter Project, and the URL is there. And you'll notice if you look at this tool that it starts to point towards end of life. But really the questions are excellent. And they are, here are the important milestones in my life. Hey, healthcare provider, you're recommending I do this, but I want you to know it's my 50th wedding anniversary next month, and I need to be well for that, or I need to not miss it. How families prefer to handle difficult news, and then to make decisions. And on this particular letter, there's some check boxes that helps people think about how they want to be treated when they're coming to the end of their living days. And you may say, well, I don't want to think about that. But the fact is, the majority of our healthcare dollars are spent in the last, you'll probably answer for me, 30 to 90 days of life. And so it is worth thinking about, even when we're healthy. So you say, okay, how do I go about that? How do I get the kind of information I need, or person needs, to know what the potential benefits of a treatment could be and what the risks are? Because fact is, treatments these days are working, and so we live longer after many treatments, and so we then have another kind of set of questions that starts to ask, well, what about the long term? So I'm going to go through a couple of these with you. So first question always is, what's my chance of living without this disease? And then what are the goals of treatment? The treatment that is being recommended, is it to help me live longer? Is it help me to be pain-free? Is it to help get rid of the disease? And then really, what does the treatment entail? And really getting very concrete, like, where do I get it? Who gives it to me? What are all the extras? Do I need to come in for blood draws in between? Do I need to go see a specialist in another location? What does it mean in a very, very concrete way? So that not only do you know how it's going to take your time and your effort, but you know what it's going to cost. And then there's all the other parts of life that enter into treatment for illness. And that is, can I continue working? Does a paycheck come in? And if not, when can I expect to go back to work? How can I start that communication with my employer? And how about a caregiver? How long will I need a caregiver? And does that person have to take off work to be able to be with me throughout the day? And then back to the treatment. So not only the location, but is this a treatment that I can get? Can I pick up the drug at the local pharmacy where I know how things work and they run my insurance and I trust them? Or do I have to go to a specialty pharmacy? And how long is that going to take to get that drug? And then finally, this is a question, I'm a New Yorker. If I were paying cash for a treatment, would the plan be any different? So it's just a thought. It's a thought about whether the treatment is worth it in terms of dollars. So these are a lot of questions. So you say, how do we do this? So this is comes from a document that talks a lot about communication. And this is my recommendation, that a healthcare provider who's a good communicator shows you respect, welcomes questions, will share the information in terms you understand. Because no matter how experienced or how smart a healthcare provider is, if she doesn't listen to you or can't communicate the plan in a way you can understand, your care will not be the best it can be. So it's okay to ask for another appointment. It's great to get a second opinion, and it's okay to switch providers. And then as a patient, we are good communicators if we're mindful of the limited time we have with our provider, we're concise in our communication, and we ask for the meaning of words and concepts we don't understand. So this is a very long list. This is for your reference. This comes from the NIH. This is a set of questions to ask if you have a new healthcare provider. And really it comes down to access, and meaning, where's it located? How can you access them when you need help? Who do you call for what? How much do you have to pay? So tying this back to insurance, your insurer is your advocate. And I've learned this personally, and I've learned this working with people as patients. And that is, they do their best to try to understand what the benefit of a certain treatment is. They do their best to stay up to date on the best evidence that's published for them to read. And so when you're faced with a decision to have a treatment that's new to you or old, my recommendation is to talk to your insurer and find out not only will physician fees be covered and drugs, but how about acupuncturists? How about a naturopath? How about physical therapy? How about massage? So that you can enter the conversation and share decision making with the information that tells you, so you know what you have for coverage and what you may be responsible for. And then the other thing is they have contracted rates most of the time. And so it's learning. So many of these insurers have contracted with medical groups and hospitals. And so even though a hospital may charge a certain amount, there's a contract often with insurers that they've agreed that a certain amount will be paid, exchanged for a certain treatment. And I think you'll hear more about that. And what I want you to know is we as healthcare providers rarely know what you are financially liable for. We know now, we didn't before, but we now know what insurance a person has, but we don't know about the supplements. We don't know that unless we ask you about whether you have to do mail order prescriptions. We don't know that the vitamin D level is not covered. And so the more you know about your finances and your coverage, the more efficient we can be as a team in making some decisions. Now, we have advocates to help us, but the first step is for us to know as much as we can up front. So one of the information sources that insurers use in my work in cancer care is the NCCN. This is the National Comprehensive Cancer Network, and this is a group of cancer centers in our country. Stanford is one of them, and the physicians and other providers come together on a regular basis, and they compare the best evidence that is published in the literature and make recommendations on what preferred treatment is based on best evidence. And so this has been very helpful to insurers because they can rely on experts to help them understand. They also, this group can be very helpful to you if you are faced with something like cancer, because they also have these guidelines in less medical terms, And then also the National Institutes of Health is the one place that I do recommend that people go to for health information. It is relatively balanced, it is written very well, it is regularly updated, and it has information like how to make decisions with your doctor. And then, as you probably know, there are lots of organizations that will offer some financial relief. What can be quite difficult is figuring out who to access, how hard it is to access, and how much they could potentially offer. And so one place to start is called the Patient Advocate Foundation. This is not specific to a disease. This is a clearinghouse of a financial resource directory, and it's quite easy to use. It's also a great place to go when you're trying to sort out what a lot of different words mean. And you can see that word cloud in the bottom of the slide, and that comes from their website saying that words that matter. So understanding the difference between a deductible and co-insurance, for example, when we find out we have to pay for both. They have readily available people by telephone, and then that's their web address. So today, I think a lot of our conversation is meant to be around chronic illness. And I have the real honor of working with people for many, many years. And sometimes they'll come to me and they will have been treated 10 or 20 years before. And what I can do for them is dependent on the information I have. And healthcare institutions are not required to keep healthcare records for your lifetime. Each state varies. In certain states, it's only 7 years. And so my greatest recommendation for you tonight is to think of healthcare records like a tax return, and to keep them, file them away, and to have them available so that when things come up as you age, you have those records to draw from. When questions come up, you have a ready source. And there's some different ways to do that. One way, and more, is using the electronic medical record. My Health, or a similar name, is attached to an electronic medical record company called Epic. And that's a great way to download current information. But I would suggest that you download it so that you have it in your personal files as well. So in closing, if cost is a concern, ask the healthcare provider if less expensive choices are available. They almost always are available. But again, going to a simple prescription, you may get to the pharmacy and they'll run the generic cost and the insurance cost and the discounted coupon cost. But if you know some of that when you're in the room with the healthcare provider, it may save you some time and effort. Discuss treatment choices. Keep asking questions. It's your body. Ask about the pros and cons. Ask about things like, should I consider a clinical trial? Should I see a geneticist? Are there other places that I should go for an opinion? And then always integrate that information with your own values and circumstances so that you can make the best decision for you. And last is, people will often ask me, what is the one question to ask my healthcare provider? And it is, what questions have I forgotten to ask?
Everybody still with us? It's a lot tonight, isn't it? After this next speaker, we'll take the seventh inning stretch, so that way you can kind of get a little physical there. Gary Bertuccelli is a licensed clinical social worker and also a social worker that specializes in palliative care and hospice. He has 25 years of experience as a social worker, and the areas of practice have included geriatrics, mental health, hospice, and palliative care. He also has an MDiv, a Master's of Divinity, with experience in supporting people in the spiritual existential questions of end-of-life care. Please welcome Gary.
Thank you, Libby, and hello to all of you. My portion tonight is to address the question that comes up for patients when they're faced with a serious illness and they're not able to work. It's a reality for many people, and it's a scary one. Where's the money going to come from if I can't work? So that puts a lot of stress on patients and a worry. There are some things that can help when we're in that situation. If you are currently employed and you're faced with a serious illness, needing to take extended period of time off, please check with your human resources department if you work at an agency that has one. A lot of people have fears about doing that. They don't want to reveal too much. You don't have to reveal a lot, reveal what you're comfortable, but they can be a real resource to you if they know you have health issues that are preventing you from being able to work for a period of time. And it's important that you know what your benefits through your employer are. A couple that you should know of is the Family Medical Leave Act that guarantees that your position is secure for 12 weeks. Not all of that time may be paid. Typically, people use up their vacation and sick time. But if you still have weeks that you need to be off and you've used all of that up, paid family leave is another option. That's not through your employer, it's through the Employment Development Department, and it can pay up to 6 weeks, not all of your salary, but somewhere between 50 and 60%. So that can be a help to you. If it looks like your time off is going to be longer than that, state disability insurance is something you should look into. That pays 60% of your salary for up to 52 weeks, so basically for a year. That does, it's a pretty simple application. It does require your physician to do their portion, and it's generally processed pretty quickly. The other thing that you should consider if it looks like you're going to be out of work for a year, and you're not sure how much longer beyond that, given ongoing treatment or a lot of different factors enter into that with serious illness. Applying for Social Security disability is something else you should do. And you can do both at the same time. Social Security disability is often a lengthier process, but that's a benefit that you're entitled to if you have the work credits, 40 credits. Basically, you've worked full-time for 10 years and paid into the Social Security system. The interesting thing about Social Security disability is, and this happens for some people who may have worked early in their life, then been out of the workforce for many years. If you have not worked, I think 5 out of the last 10 years, you may not be eligible. It is an insurance, and basically they are saying that you have not been enrolled in the insurance if you've been out of work that long. So that's just something to be aware of. For people who don't qualify for state disability or Social Security disability, this is typically people who they don't have the work history where they've have enough credits in the Social Security system, or they just have not been able to work much in their life for a lot of different reasons. Lower income, lower assets. Supplemental security income is available to individuals who qualify. They have to be deemed disabled, unable to work, and their assets need to be low, $2,000 for an individual and $3,000 for a couple. And that benefit qualified aliens, which means basically they have their green card for 5 years and 40 quarters of earnings. They also could qualify for SSI. And a spouse's earnings may count toward those 40 credits. For some people who don't qualify for any of those or are in the process of trying to apply for those benefits, the Department of Social Services, and those are county by county, may have some benefits available to you, general assistance benefits. Again, that's needs-based, so low income, and you don't have benefits coming from other resources, or you're in that application process and those applications are pending. Food stamps may also be an option, and the websites for Santa Clara County Social Services and San Mateo County are listed there. Those can be resources, again, for people who find themselves in the more financially strapped situations. There are other community resources. They generally don't provide a lot of financial assistance, but there may be small grants, assistance for people who are traveling long distance to treatments. There may be some resources to help with gas or volunteers that can help provide transportation. American Cancer Society is a great resource. Their website is located there, and through that website you can get to local chapters. Cancer Care Point is another great resource in the Santa Clara County, and their website is there. And we also have someone from the agency here tonight, Laura Crutchfield. Women's Cancer Resource Center, again, another resource for, they can provide, again, small financial assistance. They have some support services where volunteers may help with light chores, transportation. So it's good to check out those kinds of websites. The cost of drugs, patient assistance programs, the coupon programs, accessing those. If ever you're prescribed a medication and you can't afford it, it's worth finding out, reaching out to the pharmaceutical companies and to see what their assistance programs are. And many of the doctor's offices are familiar with these and can provide some assistance in guiding you to those. Then tapping into your own resources. Some of us have worked for many years, find ourselves ill. We do have savings. That's not how we want to spend them, but when we're faced, with these kinds of situations and worried, looking at our own resources may be a way to relieve some stresses. For some people who are in a situation, perhaps it's just a couple, children are set, they're launched and okay. Looking at refinancing our homes, looking at lines of equity, that can be a resource. We want to be smart about that and not get ourselves into debt that we can't make our way out of. But for some people, that is a resource that can help them, give them a bridge to maybe a time when they can be back to work. And personal loans can also be a help in that regard. I think it's important to know that applying for disability benefits, I've met many people who are reluctant to do that. They feel that that means that I'm never going to work again. That may not be the case. Disability may be for a defined period of time. Even with Social Security disability, that doesn't have to be forever. And I think it's important for people to know that. With Social Security disability, there's a process where people can begin starting to work again, and benefits are gradually pulled back as earnings increase until people are again financially able to provide for themselves. Vocational rehab resources in Santa Clara County and San Mateo County, those websites are listed, and another good resource. It's I think important to always keep hope in front of us that what we're going through now may not be how it always will be or has to be. Life may be changed and different forever, but it doesn't mean that there isn't a possibility for us to be productive, for us to have some sense of being financially okay. So, thank you. That's it. One last thing. Please use your social workers. Every service line at Stanford has social workers available. They are a great resource, knowing about these and other community resources, helping you kind of think through coming up with plans. So don't forget that we're there for you.
It's not every time that a person gets to introduce themselves, but I'll do it. So I'm Libby Boatwright. I am a certified financial planner and have been for 30 years. I'm also a board-certified chaplain, so it's an interesting combination. But most of my financial planning is pro bono, but I certainly appreciate the fact that we can present this night with that kind of thing in mind. I am the chaplain for outpatient oncology, palliative medicine at Stanford Healthcare here, and I've been in, as I said, financial planning for 30 years. I specialize in the integration of medical services with community and faith-based resources to assist individuals in making optimum choices in their health care, in their spiritual and emotional health, and quality of life choices. That's kind of my lifestyle. So I've called this talk Defining the Delta, which, you know, if we talk about navigating the Narrows, it has all those waterways and so on, and the delta would be the difference between getting to the place you want and maybe where you are. And so a delta both has the waterway, but also the idea of financial planning. So we're going to begin at the mouth of the river and take a snapshot. And so what is your location? And what are your reserves? What's in the boat? I usually say, as a financial planner, 3 to 6 months of expenses in the bank. And some people are going to say, are you kidding? I can't do that. But you know, when you think about it, especially if you are in a disability situation or something else, that 3 to 6 months is a very nice reserve to have handy, because you may find yourself out of work, as Gary has said, and those reserves then serve as a way to get through that delta, if you will. Also, insurance to cover the catastrophic. Most people, sometimes they have a concern about life insurance and how that works. But if you have a young family and you're concerned about income or what might happen should you not be here, the catastrophic illness or the death in the family, insurance can be a very helpful thing to assure you that there'll be provision and income later on. And then 25% equity in the home. Some people say, wait a minute, I went through the year 2000, I went through 2008, that's impossible. But I encourage you to think about this because we have had downturns. We have had times where the upside, downside part of the home industry has been very, very critical. And people have lost the value of their home, and we have to watch in terms of how much we borrow against it and so on. So I encourage people that before they go on any kind of journey or any kind of investment or any kind of thing in this delta, that they look at the possibility of having 25% income equity in their home. Then there's the inventory of assets and liabilities. Again, if we're looking for resources, what is it, as Gary has said, that we've saved up? What are the things that we could expend in the event that we need them for a critical illness? Cash flow, what are the monthly expenses? Is there more month than money? I hear that all the time. You know, I've got to this paycheck and I've got 5 more days, but I don't have any money, so what am I going to do? It may be time to do the B word, which is called the budget, and decide where is the cash flow going, and are there monies left at the end of the month that I can save towards this new situation I have in my illness. Are there pockets of cash and resources that might be utilized? Gary mentioned lines of credit, but I also think of savings with no interest. I think of CDs coming due, but beware of the income and the tax implication. I also think of tax savings accounts. Many of you may be in an employer where you save a certain amount every month, and that money is sitting there as a pre-tax benefit to you, and then could be paid out for the medical needs that you have. So then I'm going to talk about raising the waters. Well, consider the tax efficiency and loss of compounding. When you take away that money, you lose the compounding. You may lose the pre-tax and other things. So stock and stock options, we need to be careful because the cost of the option or the gains or the taxes all come into play. And I encourage people that if you are in one of those wonderful .coms and you've got lots of tax options or stock options coming due and it looks very enticing, make sure you check in with a tax advisor. Because remember, you have the gain, you have the option cost, you have so many things involved, and what you may think is this big, huge landfall of all this money, maybe 50% of that, once you pay the taxes, once you've paid your gains. Also, 401k plans are very tempting. Again, there's caution because loans can be obtained against the 401k that you have, but they have to be paid within 5 years with interest that the participant pays to him or herself. And so it's limited to $50,000 or half of the vested balance. So if you have $100,000 401k, you can then borrow against that $50,000, but that's the limit. And it must be paid back within 60 days upon termination. So say if you are eliminated from your job, you have 60 days to pay that back. Or have it count as a distribution with income. That's a pretty expensive way to get more income. And tax and penalty if you're under 59 and a half. So consider all of those things before you take a loan out of your 401k. Over 59 and a half, you still get taxed for the income, but there are no penalties. 59 and a half is that magic year where you can start taking from your retirement vehicles. Okay. IRA funds before 59 and a half, again, penalties and taxes are there, but after 59 and a half, no penalty. And you cannot loan against IRA. You can loan against a 401k, but not an IRA. And after 5 years of investment with a Roth, no taxes upon withdrawal. So some of you have made those Roth conversions and you think maybe that would be a pot of money. Wait the 5 years if you can before you make that withdrawal. And then home equity loans. We all have heard about the magic $100,000. It has not gone away with the tax reform, thank goodness. So what is the renegotiated payment if you make that loan against your home? What's the length of the loan, the interest rate, and how will this impact my total budget? You know, you've already got that budget that may be stretched. With the extra loan, is that going to really stretch it beyond your means? So raising the waters, a little different. Gifting, $15,000 is allowed from any individual to another. So this is where if Auntie Sarah says, honey, I want to help you. You say, yes, Auntie Sarah, we definitely want, that's okay. $15,000 tax-free to me, no problem with you. This is a good thing. So if you have all these aunts and uncles that want to raise the waters for you, this would be the year if you're struggling with finances because they can give that to you $15,000 per person, per individual, tax-free, gift-free. It's lovely. Benevolence. There are 501(c) faith communities and community agencies. Some people have specific benevolence funds in churches, mine does, and people can come and say, I'm having a problem. And they have special funds that are set aside for this purpose. So if you're part of a faith community or affinity group or support group, they may have already set aside those funds to help you, and you can make that appeal. Keep in mind that people cannot give to such an account on your behalf. It has to be a general fund that is then distributed based on a trustee or someone that makes that decision. Private family loans with a contract or a promissory note are also possible. Keep in mind it becomes that relationship. What is it going to look like at Christmas if you haven't paid it off? That can be a great holiday. But the idea, again, is some people would like to do this and they want to do it privately, but the suggestion that I make is that you always have a contract. Make it a promissory note, not a handshake. You want to retain your good relationships with your family. And then the GoFundMe accounts. This is the latest thing in the tech industry where someone says, let's raise some money for Sarah or Sally or Freddie or Frank or whoever, and they can then build an account on your behalf. It's not going to be tax deductible, but it is a gift to you, and sometimes that's a great gift of love, so you can think about that. Avoid the following. I cannot tell you how many times I've had to pull people out of the mud. Payday loans. Oh my goodness. Payday loans. These are generally loans that are done with people that are making a profit, and their profit is somewhere between 50 and 30%. It's not a good idea. Loans against the equity in your car, another issue that comes up when people are desperate for money. They often say, well, there's this car guy, and if I just, borrow against my car, I paid it off, then they'll give me all this money. It comes at a cost. Special bank checks. Anybody get the little bank checks during Christmas? The ones they pre-printed with your name on it, and they don't look like your other checks, but they're cool checks. They're 19 to 27% interest. Consolidation loans and debt repair companies, again, 15 to 27%. These are all places that we would want people to avoid. And then the famous phrase, I've got this friend, who can loan stuff to you, and he's just a great friend, and he'll make it work. But if it's not a contract, if it's not a promissory note, if it's not official, who knows what this friend is really charging you? Rebates on cars and vehicles. I'm always amused at what happens when people buy a new car and they say, we got this great rebate, $6,500. Does everyone know that they refinance it into the financing of the car? It is not a free gift. And if you look at the fine print, that $10,000 they said was off the MSRP and this wonderful bonus is already financed into the car payment that you're making. So it's not a deal. So you can avoid all those commercials on TV. And then upfront tax rebates. This is the season of the tax rebate now, and everybody say, we'll give you $2,000, $3,000 up front. Have they told you the terms of it? Have they told you what their fees are or what they're going to charge? So again, these are things that are for-profit schemes that are aimed at the person who's in a desperate situation, and we would love for you to avoid them. So what are some of the rescue efforts? Well, two places that I tell people about, and I'm sure possibly Anna and Phyllis will talk about this. The National Foundation for Credit Counseling is one of the oldest organizations in the country. They have trained counselors in credit counseling and also in budget and financing. They work as a nonprofit. They work with creditors, and they create a payment plan, which is very different from someone who's got you on their credit list. And then pro bono financial planning. I'm part of the Financial Planning Association here in Silicon Valley. We offer 4 times a year free financial planning to anyone that comes to a library or a senior center, community center, wherever it's offered. And you get a half an hour to an hour of free financial planning. So again, that's against what often financial planners would charge, somewhere in the $1,500 a plan. So it's a good deal if you can do it. So one of the articles that I've read recently is actually a very good one by Lydia Shapira, and it's in cancer.net, having the cancer cost conversation. And this could be any conversation, not just cancer, for chronic illness. 5 places to start. You ask your care team or cancer care team, discuss the financial impact. And I think Kelly mentioned that very well tonight about, ask the question, say, is there another way? Is there another alternative? Speak with your specialty pharmacist. Again, a very good idea because there are many specialty drugs that cost a great deal, and special medications and solving problems might be done at a discount if you ask those questions. And then, is there a financial counselor? Yes, there are, and we have 2 coming tonight, where you receive your treatment to identify additional resources to help you cover costs and find cheaper alternatives. We're blessed to have 2 ladies here tonight. Reach out, as Gary said, to employers, Human Resources Department, or the insurance company, and finally, contact the patient advocacy organizations. We've covered all those points in the past, but this is a good way to just kind of consolidate all that wisdom. One of the things I tell people is keep good records and stop the river of denial. Everybody's heard about the Nile? This is the river of denial from flowing into your life, as long as we keep this Delta idea going. And then there's some suggested websites that I've suggested for you: the Tax Policy Center, the Bloomberg Tax, Cancer Bills and Insurance. Here's what happens when you take out a loan. These are websites that are very helpful, that have multiple articles on how to find those additional resources outside your own resources at home. And I've added my name and number there. You're welcome to call anytime. Okay, thanks so much. Okay, we have our final group of speakers. We're so blessed tonight because these are people that I've been watching and been very excited about. Anna Brown, used to be Anna Quintana, but is now Anna Brown, just got recently married, exciting. Has over 20 years of experience in healthcare with 5 years with financial counseling at Stanford. She has worked several positions from the front end, back end, with majority of positions being in the revenue cycle. She has a passion in assisting patients understand their benefits and how to access care at Stanford. She most recently was awarded the CI Care Spotlight Award. This is a very big deal, in August of 2017, recognizing the action she took to help a patient attain the care she needed. And then also with her is Phyllis Garza, who has over 30 years of experience. I added the experience up tonight. It's over 150 years. This is amazing. In the medical field, and has been at Stanford going on 25 years. And in her experience, the positions she's worked were primarily in the front end of the medical field, specifically medical receptionist and records, authorizations, registration, and insurance. She has over 9 years of experience as a financial counselor advocate at Stanford Healthcare, and she works closely with patients, physicians, and the clinical coordinators to ensure that our patients have an insurance benefits coordinator that is part of their team. Please welcome Anna and Phyllis.
Thank you very much. Good evening, everyone. And thank you so much for coming. We are extremely excited to be here for you. I'm Phyllis Garza, financial counselor, and this is my colleague.
Hi, everybody.
As financial counselors, we are part of Patient Access Services at Stanford Healthcare. We are a dedicated team, and we serve as a resource to our patients in understanding the financial aspects of their care. As financial counselors, we strive with compassion and sensitivity to make the financial concerns surrounding our patients' medical needs as stress-free as possible. One of our main goals when we work with our patients is for you to have the ability to focus on your health and recovery instead of cost. After all, what's more important? Your care and well-being.
So as financial counselors, we partner with patients and their families to understand their insurance plans. How does my insurance work here at Stanford Healthcare? And the type of coverage, what type of medical services are covered under my plan, and patient liability based on our contractual rates, not our billed charges with insurance companies. We also provide financial assistance options. Stanford does have a very generous financial assistance program, so that's definitely an option out there for our patients. We also provide estimates for medical services. How much are you going to bill my insurance? What's my portion going to be? So we definitely provide estimates for all service lines. We also provide estimates for services that are not covered by insurances. Now, there are some services that Stanford does provide which insurances may not cover due to the fact that they may consider them experimental or investigational, because we are on the cutting edge of medical technology and services. So there's definitely options for our patients in terms of those costs with those non-covered services. And we also act as a liaison between patients and insurance companies. Let's face it, sometimes insurance, they talk insurance lingo, and if you're not familiar with the lingo and speaking with your insurance company, that's where we come in. And we can definitely bridge that gap and communicate what your insurance is trying to communicate to you and vice versa.
So some of our responsibilities include, as Anna just mentioned, communicate with our patients and insurance carrier on the phone. We are the voice for you. We know what terminologies to use. We know about your diagnosis. We understand CPT codes. We understand what benefits mean, co-insurance, out-of-pocket max. So that is for us to get for you and to help you understand your plan so that we can figure out what your next step would be. We educate our patients about payment options and financial assistance at Stanford Healthcare. What if this is an out-of-pocket that I can't afford? What do I do? How can I take care of that out-of-pocket responsibility? Stanford does have an extensive financial assistance program. We're here to assist with that. We're here to help you complete your financial assistance application and to send it to the team that processes that application for you. Excuse me. We work very closely with patient financial assistance. That's the team that processes the applications here at Stanford Healthcare. We will work with you. We are at the hospital. Anna's our designated financial counselor at our neuroscience facility across the way. I'm at the hospital, including with a team, and we're part of the admitting department, which is part of patient access services. What we do is we will complete that application with you. We'll share what's required with that application, proof of income of some sort. We'll scan that information over for you, provide you the phone number. If you prefer to do it yourself, we're going to give you that fax number and phone number so that you can call and keep up and understand the status of your application and hope that it's going to be approved so that when you have these medical services, you don't have to worry about anything other than getting well. We assist our patients with payment arrangements. Okay, so what if I don't qualify for financial assistance? It's based on income, but I have an out-of-pocket. How can you assist? What can I do? Well, we'll make sure that you understand our billing department and how we can set up payment arrangements to help you with those expenses. We also explain the total cost of the planned treatment, the patient's out-of-pocket. So as mentioned earlier, there might be a treatment plan that is not covered or is experimental, but yet we want to move forward. Our family, the patient wants to move forward. So we're going to be part of the team. We are on your team. We are part of your team as your surgeon, your medical assistant, nurse, financial counseling. Together as part of your team, we will help you understand and ensure that we take care of not only your planned treatment, but that out-of-pocket patient responsibility.
So as financial counselors, we work hand in hand with Stanford Healthcare's vendor, MedData, and they are located actually in the hospital. This team is available to screen patients that are either uninsured or underinsured for potential Medi-Cal. And underinsured would be a patient who potentially has like a limited plan. We also work closely with our social workers and case management to assist any discharge needs while patients are in the hospital or any outpatient needs as well. And we love going the extra mile. This is actually my favorite part of being a financial counselor. It's not unusual for us to become personally invested in finding help for patients. As financial counselors, I think when someone is saying no, we're trying to find the yes and trying to help the patient as best as we possibly can. So we form a lot of relationships, lifelong, I would say, bonds, and it's really one of my favorite parts of being a financial counselor here at Stanford.
And just to piggy off of that, we work very closely, with our social work and our nurse case managers. Again, as part of your team, we try to ensure that all of us are on the same page. Your medical team, social work, case manager, financial counseling, and to make sure that we communicate the exact same information to help you understand what the next step is. So at the end of the day, everyone, keep in mind financial counseling is part of the overall well-being of our patients, of you. Again, we are the voice for you. We are here for you as much as possible in regards to any type of financial question, situation, assistance. We understand being faced with possible stress of a diagnosis. It helps, and we understand our patients to have an expert who explains the insurance coverage, benefits, financial assistance, and we also serve as a resource as needed. What we have for you are some awesome links, helpful links. We've got our stanfordhealthcare.org link. Quick links, you can access the financial assistance application. You're able to call us. There's our phone number for you. We have an FAQ on this link to explain what insurances Stanford takes or do not take. We also have the billing information for you as well. We have an awesome link. We work with this team. We refer a lot of patients to HICAP. We mentioned that earlier. This is for patients that have Medicare insurance. This is a team that offers free, objective information and counseling about Medicare. And then we have here the Cover California link for you to understand what plans are offered to you in your counties. I want to thank you very much.
Thank you very much for having us. So please reach out to your financial counselors. We are definitely here to help you. Spread the word. We love to help our patients. And like I said, when the doors are closing and saying no, we're trying to find that yes until we exhaust all avenues. So
Take care, everyone.
thank you.
Thank you.
Well, we are blessed with about 15 minutes for questions. So if you've been saving up that juicy question you want to ask the panel, this is your chance. So just raise your hand. Yes, please.
If we would decide to do,
I'm going to give you a mic. That way we can hear. Yeah.
I hope you understand me. Okay, if we would decide to do, the doctor and the patient decide to do a clinical trial, either for cancer drugs or another, like a medical equipment, stuff like that, is there, I assume those drugs are not in a tier because it's not FDA approval. So does this mean the pharmaceutical companies or medical equipment company can charge as much as they want? And are there any financial program with Stanford?
That's a good question. So who wants to take that on? Kelly. Okay.
So clinical trials are set up with a financial agreement. When the clinical trials are established, there's a financial agreement. So the physicians, investigators will know whether the drug is being paid for by the pharmaceutical company or not. What's typical is that the drug may be covered, but all the what we call ancillary services are not. So every visit, every lab, every special test. Now that So then the insurance is asked to pay for all those ancillary tests. Do you want to add to that, Phyllis?
Yeah, my husband's insurance backup plan is basically no deductible, and Plan F basically, if so in other words, that's Medicare takes that, pay for the clinical trial. So if as long as his backup plan with the Medigap plan, it's a 100% coverage. As long as Medicare pay 1 penny, then it's everything set. But it's just wondering if how does Medicare works with the clinical trial?
Okay. Does the financial counselors want to take this on?
We are not extreme Medicare experts, but we will definitely call Medicare for you. But we do know that Medicare pays based on medical necessity, right? Obviously, for inpatient services, Part A and Part B is needed for outpatient services. We consult the clinical trial coordinator which I suggest doing as well. Can you think of anything?
Connie can get the rest. Isn't it great to have 5 people that are ready to go?
No. So the Medicare supplement and Medicare in general typically won't pay for anything experimental. So it's going to depend on how that clinical trial is positioned, but that is the general rule. And as you mentioned, they'll pay for anything medically necessary. But that's not to say that they're going to think that a clinical trial is necessary. So it certainly is something you'd have to explore. With the carrier, your agent could help
Connie,
you.
pull it up a little bit.
Your agent could help you do that, but it's not guaranteed the coverage would
So
would
what
be
I'm
there.
hearing is kind of a tiered thing. We want to cover the first thing, Kelly, see what's covered, what's available, then to check in with your insurance person to see what they can do, and then maybe financial counseling can jump in. So you have maybe 3 tiers, and after that, you kind of exhausted it. But it's good to do this up front. What you're doing is excellent because you're getting your facts first before you jump in, and that's very helpful.
That's a great question.
So I'll
Very
add
good
one more
question.
thing. When you're talking to the principal investigator and asking what's being paid for by the trial, and they say, X, Y, and Z, and then you just need labs and visits. So find out a little bit more about what those labs and visits are, because that then is reflected in what Medicare, they're looking at people in one way, and the trial may be asking for more tests to evaluate the effect of the therapy that may be more than what Medicare thinks is reasonable. So knowing some numbers about what kind of blood test, how frequently, et cetera.
Does that help?
Before we jump in this one, so who could we consult with at the Stanford?
Well,
Did
I
you talk
think-
to the doctor?
yeah.
Doctor recommend that, and then okay, that's interesting.
What I'm hearing is talk with the managers of that trial first to find out the scope of what's going on, to find out what's covered, what's not, then to check in with your insurance as a second tier to find out what could be possible based on the medical necessity. And then if we're still not quite there, the financial counselors can say, remember, they're the yes people. They're going to try to find the other part to see what's available. I'm holding you accountable here, ladies. To see what's available, because you want to have the full package before you say yes. Does that make sense? Okay, great question. Really good question. Anybody else?
Yes. Are the Medicare supplemental programs limited by pre-existing conditions?
This would be a Connie question. We're going to have the mic, yeah.
That's going to depend on when you're enrolling.
Pull it up, Mike.
So during that initial enrollment period, you're guaranteed a plan, no medical questions asked. But later on, you may not be in a guaranteed issue situation, and each of the plans will ask medical questions. Some are more stringent than others, so you want to look at that. But most of the time, they are going to ask you medical questions, okay, unless you have that special election period.
Okay. Next question. Any other burning questions that you folks want to cover? Yes, sir. We have someone in the back.
I have a question. If you collect SDI, will your employer or your former employer be dinged for money or not?
Gary, do you want to take that?
So SDI is the state disability, and that's through the Employment Development Department, and you have paid SDI taxes. So it's not employer paid.
Good questions. Excellent. Anybody else want to? Okay.
When I retired, I asked my doctor how long I was going to live, because I had to make all these decisions on whether I take a lump sum or a pension until my wife dies a little bit. And he asked me what road I was going to take on the way home. But I think if I asked one of my doctors here, I have a nasty cancer, they wouldn't say that. You know? And so they call that life expectancy prognosis, I guess. But what I'm asking is, where can I go to find out about Social Security? I've delayed taking Social Security because our needs are pretty small, or were now, and will be greater later. And so, but now with this prognosis, it's different. I've done all these calculations before that happened. Is there a good way to look at that? Because I have to look at both mine and my spouse's
Right.
benefits.
Well, I'd start with the Social Security Department because they have counselors that are there. Of course, you have to get an appointment, and that can take a little while. But they have people there that can do the same calculations that you're asking about. You're qualified to get Social Security at 62, as you know. And you can then continue deferring that Social Security until, say, age 70 and a half. At that point, you have to start taking your income out. So I would say, for me, and maybe there's differences of opinions here, is start with the Social Security Department. Give them your situation. You're on the table now. There's no secrets. And you can say, this is my situation. I need a certain amount of income, and I need it at this age. What do you recommend? Each year, you know that your income goes up according to your age until 70 and a half, and then it hits a maximum. Generally at age 66, it may be a little older for some people of a certain age, your maximum benefits go into it, and then you get additional monies after 66 and a half. So it's really up to you in terms of your income need and when you want to start the money rolling in.
And then if you pass away, does your spouse get 100% of your benefit if theirs is less than yours was going to be?
Generally, I don't know. I believe in this situation, yeah.
Been married 10 years or more.
10 years or more. So if you've been married more than one time with two different spouses, there's all sorts of things you can get. No, I'm just kidding. Don't want to start that. No. 10 years or more qualifies that for a spouse, yes. But there are some people that have used all sorts of ways to work with Social Security. We won't go into that. That's another whole story, isn't it, Connie? Yes, it would. So would that be something you could do then to make the appointment?
Well, unfortunately, when I've done that, we live in a really small rural
okay.
place, and the people they hire
Are
don't
not
have
as
much
as
education.
qualified.
Yeah,
Okay.
right.
So then the next possibility would be a good financial planner, someone that is versed in that and has experience in it. I mean, Connie obviously is the person up here tonight that has the qualified experience in Medicare. So it may be an insurance agent, it might be a financial planner. But I highly recommend you work with someone who's fee-based and not commission-based in this case. Okay. Yes.
So if a person is ill and ultimately loses their job after the 12 weeks of family leave, I know you can do something like COBRA for 18 months, but what happens after that?
Do you want to take that, Gary? Okay.
So after that, if you're still not able to work, during that time where it's looking like unable to work longer, you should begin applying for disability benefits. Depending on the date that you're determined disabled, then the counting starts toward the 24 months you need to be disabled to qualify for Medicare. In between that time, it would be going to the marketplace, the Covered California, to look at plans that may be affordable.
So you can do, most places you can do COBRA for 18, but you can't get Medicare until 24. So are we talking about a 6-month gap there?
Roughly.
Could be a 6-month gap. It depends. Some people will apply for disability, but maybe they've been unable to work for some months before that. Social Security looks at your medical history, so they may determine that you were disabled a few months before you actually applied. And all of those months count toward the 24 for qualifying for Medicare.
Keep in mind that COBRA can be a little bit expensive because they actually make you pay the amount that the employer pays, not so much the discount of what you would normally get as an employee. So something to consider.
And some people actually choose to look for alternate plans on the marketplace, on the exchange.
Versus
Yeah.
COBRA. Other questions? We've got about 5 minutes. Oh, I'm sorry. Yes, go ahead, Phyllis.
If you choose to plan on the marketplace, give us a call, especially if you're patients here at Stanford Healthcare, so that we can provide information to you to ensure that it is a plan that we accept here at Stanford.
Good point. About 5 more minutes? Yes, someone in the back here, please.
The Social Security Disability website, there's a 800 number that you can call, and they're really good.
Good.
And they have a lot of really good information, and they'll give you like a caseworker that you can, for more questions, you can call them back and they'll help you out.
That's excellent. I think the 800 numbers, again, as you have access to them, I'm sorry you are living in a smaller town, so that's a little harder, but you might try the 800 number and see.
Wait 2 hours or so. And then
Yeah, it's a long time, yeah,
Well, you can meet with somebody in a different area.
That's better.
yeah.
Right.
At least get the facts right. Okay, yeah, here you go. You've got financial counselors right here. Okay. Other questions? Yes.
I actually have a question myself. How much is it to see the financial counselor or like insurance broker?
Okay, so Connie, why don't you start? How much does it cost? Is there a fee involved when you visit an insurance person?
A broker does not charge any money, and the only way we get paid, regardless of how many times we meet with you or how long we meet with you, is if you enroll in a product, and then that carrier, that insurance carrier, would pay us a commission. So you never pay an insurance broker anything. If they are charging you, then I would go elsewhere.
Okay, and so our financial counselors, tell us about how you charge.
We charge just by being there for you. That's our fee. Our smiles, our personality. So I don't think that's going to be too much.
Okay. So free services here on the campus, and then when you work with insurance brokers, they are on a commission basis, but again, you're receiving a product as part of that. Other people, is that good, Esther? Good, okay. Anybody else that has a question before we end tonight? We might get a reserve of 3 minutes. Yes, okay. All right, yes, please. We have one more question. What?
I think it's a pretty dumb question, but listening to all the wonderful services that you've all described, I assume that everybody who's available for them is someone who's involved in Stanford healthcare by a doctor, as I am, for example. But if you're not, and you're not an employee, are you still in the game? So, like you just at the end started to talk about some of these things you talked about have fees that are naturally understood, but some of the things we've experienced so far in just a month of getting involved in all this is that Stanford has a lot of free things that they're doing, like your presentation tonight. But I don't know if that all comes from being signed up with the what do you call them? Oncologist, or that you work here. Can you please someone explain how that works?
You want to start financial planning, ladies, or?
Financial counseling services are available to anybody, whether you're a patient of Stanford or outside looking to come into Stanford. Our services are there for patients. So under no circumstances do you need to be registered in our system for a financial counselor to speak with you. Anyone can just walk into the hospital, main admitting, and request to speak to a financial counselor, and we will definitely be there to assist. Yes, so you don't have to be a patient registered in our system.
And I think everyone else works in some kind of provider situation, except for Connie. Connie's an independent. So if you approached her for any reason, she would have her own fee system. Zero, which is zero. But she is product-based, and it is commission. So that's something, as I said, I think you mentioned is understood.
I'll say one more thing, but as a broker, I work with all of the insurance companies, and so I'm not partial to one or the other, and I find what fits for you rather than vice versa. And so still, it's zero.
So you're a financial broker, but skilled in health stuff, I bet.
Well, I'm an insurance broker. I am not a financial advisor or anything near that. So
But-
strictly just an insurance broker.
You never knew they existed.
They do.
Oh, yes, they do. It's very nice to have one. And yes, medical and life. I do have travel medical. I do.
Okay. So I think we're at time. Is that correct? So I just want to thank everyone for coming. Darla, do you have some final words? Thank you so much for being here tonight.
Great. May I say one more thing? She just asked me how to find me. My cards are on the table.
Okay.
Okay.
All right. Thank you very much. I hope you guys enjoyed this lecture series. We do have another lecture coming up in March. It'll be held at the Cambrian Library in San Jose. It's on skin care during cancer therapy, sun protection, and moisturizing. It's going to be offered by Dr. Bernice Kwong. She's one of our dermatologists, so we hope that you'll come again and enjoy another of our lectures. So again, on behalf of the Cancer Supportive Care Program, we really want to thank you for your attendance here tonight and look forward to partnering with you in any way we can. Okay? Thank you.